Hello, I'm Shaun Treweek. I'm in the Health Services Research Unit here at the University of Aberdeen. What I'm going to talk about today is how we discriminate between trials that are taking a more pragmatic approach to design from those that are taking a more explanatory approach. Both approaches are appropriate in their own place, but it's important not to do one type of approach when what you're really trying to do is the other. So we'll talk about the distinction between the two. The most important thing to think about with any trial is who is going to use the information that your trial will provide. Who are the intended users? For many trials, the person or the type of people who will be using the results of the trial are not people like you. So I'm not a clinician myself, for example, but many of the trials that I design are intended to help health professionals and patients make decisions. So clearly it's what they need from the trial that is important, not what I think is important. So the first thing to think about is who will use your trial results? Whose decision are you trying to improve by providing your trial? And then you make your design decisions with that person's needs in mind. Now, the reason I have a picture up here of Kirsty Loudon, who used to be a PhD student of mine, is that she, together with myself and a whole range of other people, developed a tool to help us think through whether we are taking design decisions that are matched to the type of trial, the type of user that we think we are designing the trial for. And that tool was called Tracy2, and it was reported in the BMJ a few years ago. You can see the reference here. The tool itself is described in some detail in that paper, and it would be worth having a look through the BMJ paper. But what I want to do is show you the tool, which I'll do in a moment, and then talk through some of the things in that tool that will help you think through, well, this is how it should look for a trial that's taking a more pragmatic approach, and this is how it should look if we're taking a more explanatory approach, just to tease out some of those differences, and then highlight a few examples using a real trial. The tool, to cut to the chase, looks like this. It's a wheel. And what we're really trying to think about here when we say, are we doing a more pragmatic trial or a more explanatory trial, is trials that are taking a more pragmatic approach are really trying to generate results that are of immediate utility and relevance to health professionals and patients and policymakers, commissioners of care, who are there already at the coal face, if you like, providing care. So you're thinking about a trial that will inform decisions in care as it is right now. That's what the more pragmatic approach is. More explanatory approaches generally are dealing with interventions, treatments, therapies that are at an earlier stage of development. And the users in those sorts of trials could indeed often be researchers like me. We're trying to tease out whether something could work, and we might want to control things to a much greater extent. We're not really expecting this explanatory trial to move straight into clinical practice because we've controlled things specifically because the intended user is not a health professional, is not a patient, is not a health policymaker, but is somebody like us, a researcher developing the intervention. Or perhaps policymakers who want to see some promise before pitching in more funds to develop a more fully fledged intervention. So we want to be looking at the right sort of trial. This tool helps us do that. What we're trying to do is think about how far or close are we from usual care today for our particular illness or condition. And there are 9 design domains, we've called them. This is what the spokes of the wheel are. And you work around that wheel thinking about the decisions you have made. So let's take the easiest one, which is eligibility. Who gets in the trial? Now, if you're designing a trial that is intended for immediate clinical relevance, then in that case, what you want is that the people who are in your trial are the same as the people who would get this treatment or therapy if it showed itself to be effective. So if they're candidates for the therapy out there in usual care, then they are the sorts of people you'd want in your trial. So you wouldn't be being very selective. You'd be thinking, who would get it in routine care? They're the people I want in my trial. Doing something much more explanatory, you might think, well, actually what we want here are just those who absolutely 100% we know have this condition. They don't have other conditions. Let's choose a particular age range because it's easier to deal with that group of people for one reason or another. Let's do it in academic healthcare centres, not primary care, because we can control things a bit more there, etc., etc., etc. So you're more controlling if you're doing it in an explanatory fashion. You work around the wheel. We've done eligibility, recruitment. Where are we getting our people, our participants from? Is that the same sort of recruitment path that we would use in routine care? Or are we using something which is very different? It depends on what sort of trial you are aiming to design and who will be using the results. You need to think about the consequence of that recruitment strategy on your intended design approach. Setting, are we doing it in primary care? Are we doing it in the community? Are we doing it in secondary care? It's very often the case that people do trials perhaps in the wrong place because it's easier to do it, but actually most of the care is provided elsewhere. You don't want to make that design decision by accident. Organisation, what extra skills, training, etc. are required. Very often, again, trialists try to make it easier to do the trial by throwing additional resource in terms of people and support at the trial so that the intervention can be delivered. And as soon as the trial team disappear, it's impossible to deliver that trial in routine care, that intervention in routine care. Trial teams disappeared, but without those extra resources, you can't do the intervention. That's perhaps fine if you're doing a more explanatory trial, but if you're aiming it to be of immediate relevance out there in routine care as it is now, then you've made a mistake. So you work through the wheel and you get scores. 1 would mean this is a highly explanatory design domain. 5 would be much more pragmatic, highly pragmatic. And you look at your wheel and you look at your design decisions. Are they consistent? Is it the sort of trial you were hoping to design? There are some more resources on our website. It's free. You can get lots of hints and tips about how to use the tool. There's a database that shows you how other people have scored trials. So there's plenty there to get your teeth into. And one other thing to make very clear is that the ideal use of this tool is to do it at the point of designing the trial. So the tool is designed to be used by trial teams designing a trial. It's not really intended to be used retrospectively to score somebody else's trial, although we are doing that in this course, and indeed many people do that. But it makes it tricky because of reporting. Poor reporting makes it very hard to score some of the domains using PRACE2. And there is, just for interest, there's an extension to the consort statement for pragmatic trials, which talks about the things you really need to talk about or describe and report if you are reporting a pragmatic trial. And that, if done well, would help with retrospective scoring. But retrospective scoring using PRACE2 is tricky because very often reporting is not so great. Now, before I end, I just want to give a few pointers linked to a trial which intended to be highly pragmatic. It's called the Football Fans in Training trial, and you have materials online linked to this trial. So I'm not going to talk about it in great detail. You have a crib sheet that talks about how I've scored it. There's also a video of a discussion between myself and Professor Graham McLennan, a colleague of mine, where we talk through how we scored it together. And what you'll find from that discussion is that this is a judgment. There is no absolute truth when scoring trials on PRACE2. This is what my scoring looked like for PRACE2. It looks highly pragmatic, I think. Others yourselves may disagree, but you can see from the crib sheet how I've scored. I just wanted to highlight a couple of things, one of which is organisation. Organisation is possibly one of the most tricky domains on the PRACE2 tool. And that, again, just to recap, is the extra skills and training required to deliver the intervention, or indeed are there different members of staff required and thrown at the trial to make it work? And the reason this one's important is because very often additional staff and additional support, helplines and training are not always explicitly considered as part of the intervention, when actually they are. If you remove those things, it becomes very difficult to deliver the intervention, which, if you're designing a highly pragmatic trial, means you can't just slide it in to routine care. So for FIT, the Football Fans in Training trial, we actually required a little bit of extra training from a group of staff who already existed. So that was great, they were there already, but they needed a little bit of extra training, so that was good. And actually, as you'll hear from the discussion between Graham and myself, there was a little bit of extra support we provided, which we hadn't really thought of as part of the intervention, and perhaps we should. So that's why I score it down there at about a 3 or so on the scale, not highly pragmatic like many of the others. Eligibility here, just to pick another one, we included just the sort of men who would be candidates for the Football Fans in Training programme if it was rolled out. And that was led, therefore, to a score of 5. It was exactly what we were wanting to do. The trial looks exactly the same as routine delivery.